Hello, it's good to be with you today to bring you a new Gynonc Garage. My name's Ed Pavlik. I'm in Lexington, Kentucky. My colleague today is
Frank Lawton from London in the United Kingdom.
very good. Well, we're ready to go, but Frank, I have a question for you before we do. How is the new government doing in the UK?
Well, we were in the Euro finals, so that's obviously a good thing. This is the European Cup, and clearly this is all to do with the election of a new Labour administration and Prime Minister. So it's all going to be wonderful now. Yeah, right. Until the next time.
Well, how soon will the next time be?
Yes. Who knows, Ed? Uh, I think traditionally, and maybe American politics as well. They sort of do the first 100 days. You know, Trump's first 100 days, or Nixon's first 100 days, or Boris Johnson's first 100 days. So he's got about 3 months to change things. But you and I know that so much is affecting the running of the country that's got nothing to do with the country itself. You know that the war in Ukraine, COVID, interest rates, this, that, and the other. It's got global warming. It's got the government can't sort all those out. Any government can't all sort that out. So it'll be very interesting to see. Anyway, in 3 months' time, when we do our 3 monthly thing, we can talk about Sir Keir Starmer. It's very interesting. This is apropos nothing that there have been two Keirs have been Labour leaders, and there have been no female Labour leaders. We've had Margaret Thatcher, we've had Liz Truss, we've had Theresa May in the Conservative side, but there's never been a female, and we've already had two Keirs as leader of the Labour Party. I don't know what that means, really. I don't know what it says. Anyway, shall we talk medicine?
Yes, let's talk about something that we do know the meaning of. Today, we're going to consider the question, is there a benefit to a second, third, or fourth surgery when ovarian granulosa cell tumors occur in adults? Answers to this question are approached in a recent paper from the US titled Serial Cytoreductive Surgery and Survival Outcomes in Recurrent Adult Type Ovarian Granulosa Cell Tumors. This paper was recently published in the Gray Journal, which is the American Journal of Obstetrics and Gynecology. With that said, Frank, give us your insights on this paper.
Okay, well, this is a disease that we all know with a very indolent natural history. I mean, the 5 year survival rate for early stage disease, 1 and 2, is probably in the order of 90%. And even in stage 2, 3 and 4 disease, it's not so much better than its epithelial equivalent. So if ever there was a disease with a natural history of recurrence in 10 plus years, this is the one that's ripe for surgical intervention. There's no doubt about that. And there have been numerous papers discussing surgical intervention in recurrent granulosa cell tumors. Remember that recurrent GCTs are not curable, and that's fine. I'm happy with that. The problem is what happens when the disease recurs, and what do we do? Is it further surgery or further chemotherapy? And I think this paper addresses what we've already looked at, which is further surgery, but goes further than that. And should there be further surgery, a third intervention surgery or a fourth intervention surgery? And obviously with a problem like GCT, which is so rare, they've had to look after, I think the data starts from 1970, and they've only found 140 odd patients that fitted the criteria that they wanted. But they've shown that a secondary debulking does increase progression-free survival and median overall survival. But in a way, you'd expect that because these are slow-growing tumors. If there's a disease that is recurring, but it's not going to kill you for 10 years, then removing some of it is going to improve the progression-free survival. That's not relevant, really. What they've looked at is tertiary and then quaternary debulking. And they've shown that secondary debulking does produce a significant increase in progression-free and median overall survival, as does tertiary debulking. not quaternary debulking, if that's the right word, and there's no explanation why. Is it because the disease eventually becomes unresectable, or the disease eventually becomes such that it cannot be removed? Or is it just that patients, after 3 or 4 cycles of surgery, have said enough is enough? And interestingly, although they look at there is no improvement in overall survival for all of these, looking at patients who've had surgery versus patients who haven't. And that's because clearly this disease is not curable. Well, it's curable by surgery if you're lucky to have stage 1 disease or stage 2 disease, but if you've got recurrent disease, it is not curable. All it's doing is pushing out the progression-free survival. My real problem with this paper is how it's obviously it's retrospective. How was the diagnosis of recurrence made? Because clearly, if the diagnosis was made on a rise in inhibin or estrogens or whatever tumor markers they're looking at, that might be a very small recurrence of disease. If it's going to be on CT evidence, how often are the CTs occurring, and when was the decision made on a possible recurrence to do the surgery, or was it based on patient symptoms that they were having symptoms of intestinal problems or whatever it is? And obviously, I think in a slow-growing disease, that's quite important, because if you make the diagnosis you make the decision to make surgery when you've got very small volume disease based on a tumor marker versus a surgery when you've got disease based on abdominal symptoms or a large appearance on X-ray or imaging, then I think that will make a difference. So I think the paper misses out really on how that how the diagnosis of recurrence was made, and when the diagnosis of recurrence was produced and to further surgery. I think that's quite important. I think the other thing is that obviously the paper can't do this, but whether or not further surgery versus further chemotherapy is important, and I think that's a further thing that the paper cannot address. That if we've got second or tertiary recurrence, small volume disease based on inhibin levels, is it better to treat with further chemotherapy, BEP, or whatever it is that is important, or immunomodulators, versus surgery? And I think what this paper does is say, yes, we can operate. It does seem to have some sort of prognostic significance, but what that prognostic significance is unknown. And because the disease, frankly, is so uncommon, I'm not sure we'll ever get an answer, to be honest, unless a large number of institutions, I think this came from was it the MD Anderson? But a large number of institutions get together and do a prospective study, because I think this is now looked at retrospective studies, and we've gone as far as we can with it, I think.
Yeah, I agree with you, Frank. I will point out that on the secondary cytoreductions, they did report an improved overall survival. So the question was, and that was a hazard ratio of 0.28, so that's dramatic, but it was compared to it was 181 months compared to 61.
Oh, sure.
So they did get that, but really the continuation of what you just said is that you have a disease that when the recurrence occurs, it's at a long interval, so that takes up time on the clock, and you probably run out of time eventually when you get into the tertiary cytoreduction group,
Absolutely.
as well as in the quaternary. And so there's nothing reported in this paper because probably the numbers dwindle. The other thing is you've noted is that when we talk about the cytoreductions, we have the candidates for those cytoreductions that did receive cytoreductions, But inside those candidate groups, there are a lower number of cases that were even resectable. And then those that were resectable, we have no real information how many of those reduced the amount of burden to zero. Okay. And so taken together, the major headings are secondary, tertiary, and quaternary, but within those, we don't really get a good feeling for what's going on. So, the last thing I would really say about this is your point. I rebuild it, and that's that. Is the disease different as you go for longer and longer and longer periods? In other words, approach quaternary cytoreduction. Is that some sort of selection where both the body and the tumors, become more suited for embedding into the tissues, rejecting treatment, and that type of thing? And so you also not only have time that you're working against, but you're working against the development or evolution of disease that may well be different.
Oh, sure. I mean, obviously, this is disease that's indolent. It's been sitting there since primary reduction, cytoreduction, thought to be curable, which it is in 90% of cases. It comes back in 10 or 15% of cases after an interval of perhaps 5, 10, even longer years. Has the disease changed in that 5 or 10 years? And they're starting again, these authors starting again, right, this is now what we will call it recurrent disease, but let's begin again at the beginning and see if we can cytoreduce. So they're almost going back to the beginning and say, right, we can cytoreduce again. Then they do it again at secondary, at further recurrence. Then they do it again. And as you said, the natural history of this very indolent disease may be that it changes every time it recurs. And so the implications, the advantages of surgical cytoreduction diminish. And obviously, patient age increases. So there may be patients who are not suitable for surgery, who would have been for secondary, but not at tertiary. So I think it opens a lot of interesting questions, which really can only be answered, I think, with a randomized study. But I don't think, to be honest, that we're not going to be able to get numbers to make any real impact into the role of secondary, tertiary, quaternary, or any other surgery in this very, very rare disease.
Let me raise a point that is unfounded, but my impression of disease that recurs, if it recurs as a mass, it's much more removable. If it occurs in multiple sites, things don't look good. Okay. And we don't really have information about that picture, in the paper.
Not at all. Yes, and obviously disease that recurs because or recurrence is made diagnosis on a serum inhibin or serum estradiol levels may be very different from a recurrence that because a patient has complained of abdominal discomfort or on CT. There's nothing as to how these patients were followed up and how the diagnosis of recurrence was made and the interval between the diagnosis of recurrence and the surgery. None of those are available, which I think weakens the paper. Although, as I've said, I think it's interesting. It shows that with something that's indolent, surgery is maybe appropriate. It seems to produce some sort of short-term or medium-term benefit, but it's not going to actually affect the survival. This is a long-term disease that, if it comes back, unfortunately, is not curable.
Absolutely. Well, that wraps it up, Frank. We're on to seeing each other again in a month.
Indeed.
Okay. It's good to see you.
See you.